for inviting me. My name is Wojtek Morzycki. I'm one of the thoracic oncologists in Halifax at Nova Scotia Cancer Centre. And congratulations to AstraZeneca to conduct this important trial. So maybe before I'm going to make comments about this extremely elegant presentation by Dr. Paz Ares, is that the standard of treatment right now for locally advanced non-small cell lung cancer is concurrent chemoradiation therapy. And this is a large proportion of patients. Almost 1/3 of referrals with lung cancer are the patients with locally advanced disease. Small proportion of the patients can be operated, but majority of patients have inoperable disease. So they are treated with concurrent chemoradiation. It's all standard. But overall survival for these patients is unfortunately only 15% at 5 years. So I was, impatiently waiting for the result of the Pacific trial. Just a few comments. This is a large trial, double-blinded, randomized trial, placebo-controlled, multi-center, multinational, because this 26 countries participated, looking at the difference between concurrent chemoradiation treatment standard, followed by a year of the durvalumab, known before as the MEDI 4637, versus placebo. And this is very important to mention that what we heard today, this is interim analysis, so the trial has not been completed yet. But the numbers are astonishing. We have, first of all, a median progression-free survival of 17 months versus 5 months in placebo arm, with a hazard ratio of 0.5. This is strong numbers. I have not remembered recently any trials in which interim analysis would have the hazard ratio of 0.5, favoring study drug. The other endpoints are also very favorable. Time to death, time to developing distant metastases. I was particularly interested to look at the toxicity profile, particularly pneumonitis. So first of all, we anticipated some of those side effects, this immunotherapy drug. But the pneumonitis was something I anticipated would be higher because those patients are treated with radiation, and radiation sort of prones those patients to have pneumonitis. And actually, the rate was higher as I anticipated. However, the grade mainly was grade 2 and 3, so manageable. Other endpoints, we have to wait for overall survival. This is very important. I believe this is going to be a positive trial, and OS will be positive. We'll have a new standard of treatment. We've been waiting for something new in this treatment for a locally advanced disease for almost 2 decades. Nothing has changed, and those patients deserve to have something new and live longer. I think OS data will be important to present. We are in the middle of the trial, and I believe OS will be probably presented or will be analyzed next year. For Health Canada and PCODER, it will be very important to have the OS, I would say, for making the plus. If we anticipate this to be pivotal trial, and I believe it will be, OS data will be important. And I think what we see already in an interim analysis, particularly with the PFS having hazard ratio of 0.5, I believe this is going to be a beautiful positive trial. I think I would like to make 2 additional comments. I think the idea of having a future trial with the concurrent chemoradiation plus immunotherapy is very interesting. I also like the comment made by the speaker who was chairing the meeting, who believed that Pacific trial is the big tsunami by positive trial.